Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is evidence-based approach to monitoring menopausal HRT, MHT, with Dutch test. My name is Christopher Chu. I'm the Director of Marketing for Avexia Diagnostics and will be your host for this webinar. Today, I have the distinct pleasure of being joined by an exciting guest, Dr. Brook Ahnemann, who will be our presenter for this webinar. Dr. Ahnemann is a licensed naturopathic doctor in Oregon. She graduated from the National University of Natural Medicine. Before joining Precision Analytical as a clinical educator, she ran a successful family medicine practice in Portland that focused on men's and women's health, pediatrics, and complex chronic illness. She loves using herbs, nutrition, and lifestyle to support people, as well as all conventional medical tools available. Without further delay, I will now turn the webinar over to Dr. Ahnemann.
Welcome. Today we're going to have a webinar on evidence-based approach to monitoring menopausal hormone replacement therapy. Just as a reminder, and it probably goes without saying, but all of the information put forward here is for educational purposes only, should not be treated as individual medical advice. My name is Dr. Brook Ahnemann. I'm a naturopathic doctor and clinical educator for Precision Analytical, maker of the Dutch test. So our learning objectives today are that after participating in this session, we hope that you're able to understand why it might be beneficial for the patient to monitor their menopausal hormone therapy. We hope you can recognize which laboratory methods and tests are most ideal for monitoring, and we hope you can understand the value of measuring urine hormone metabolites. So first off, why monitor menopausal hormone therapy? Well, we want to optimize long-term benefits and minimize the risks. So the amount of hormone that's absorbed can be different from person to person, from route of application to route of application, and even from brand to brand. So because every patient's response is unique and we practice individualized medicine, hormone testing allows us to understand if each person is getting enough or even too much hormone. So there's evidence that a transdermal patch that has doses of estradiol that raise those levels above the postmenopausal range provides clinical benefit, preventing bone loss, hot flashes, etc. So the postmenopausal ranges that we see when a patient is not on hormone replacement, typically in serum is less than 15, in urine is between 0.2 to 0.7. And typically, when we're seeing clinical benefit for a person that's on estradiol patches, that serum level is 20 to 60, and urine levels are 0.7 to 2.4. So, for example, if a woman is taking transdermal estrogen and it's not raising her estradiol levels above that postmenopausal range, then she may not be getting the benefit of that estradiol. We see it all the time when we're doing consults. Women are taking hormone replacement, but their estradiol is still low and within that postmenopausal range. So we may still be seeing hot flashes or even longer term effects. So this is nice to have those ranges. You can print it out. So first of all, how do we monitor menopausal hormone replacement therapy? In order to monitor it, we have to first understand a few things. The difference between the testing methods, and in this case, we're going to look at LC-MS and immunoassay. What information does serum, saliva, and urine provide? What are the pros and cons of serum, urine, and saliva? And the specifics around monitoring each route of administration for estradiol, as well as the specifics around monitoring progesterone. We're going to get started with the differences between testing methods, LC-MS and immunoassay. Immunoassay is limited in its specificity and accuracy. It tends to be more prone to interference. A lot of times we talk about that with biotin. Estradiol ranges can greatly overlap. So immunoassay overall tends to be less accurate, but it does tend to be cheaper. LCMS, which is liquid chromatography with tandem mass spectrometry, is optimal specificity and accuracy. It has lower detection limits, so it's going to be very accurate even when you're testing low hormone levels like postmenopausal levels. However, it is more expensive. So let's pay attention to this with the immunoassay where those estradiol ranges overlap. If the ranges overlap, it indicates that the method is not very accurate or sensitive enough to differentiate. So in this case, between a postmenopausal female and a cycling female. It also then makes it more difficult to know if the patient's estradiol dose is too low or too high. So for example here, we're looking at the visual that's going to illustrate that. When you're looking at those saliva labs, those postmenopausal ranges and cycling female luteal ranges overlap quite a bit. So it's very difficult to know if you're in the postmenopausal range or if you're in the luteal range. And so you also don't know whether you may need to raise estradiol levels to get more clinical benefit. If we look over to the LCMS methods, the urine and the serum, there's a big gap between the postmenopausal range and the luteal range. So you very much know if a woman is in that postmenopausal range, you may need to raise estradiol levels to get her that clinical benefit. So here's the summary on what methods to use, both off and on hormone replacement. So typically we want to use LCMS when we're measuring estradiol and when we're measuring testosterone. We might want to use immunoassay when we're measuring progesterone and DHEAS. So when we're talking about progesterone, we're using immunoassay for baseline progesterone assessment. If a patient is on progesterone therapy, no lab testing ensures protection of the endometrium. So typically, if a patient is taking oral or vaginal progesterone, we don't monitor. We'll chat about that more in coming slides. So let's talk about what information serum, saliva, and urine each provide. In serum, hormones that we're looking at are mostly non-bioavailable that are in transit to tissues. Collection represents those blood levels at a single point in time. In saliva, we're seeing free hormones, which are the active hormones that have been taken up by salivary tissues. Collection also represents salivary levels at a single point in time. In urine, like on the Dutch test, we are looking at free and bioavailable hormones that have been taken up by tissues throughout the body and metabolized. Collection represents an average of levels over several hours of time. What additional information might Dutch urine testing provide? Well, we're going to get to see the metabolism. So for estrogen, in serum, we see production. In urine, we're going to see production as well as phase 1 and 2 metabolism. Same for progesterone. In serum, we see production. Urine, we see production as well as metabolism. DHEA, testosterone, again, production in serum, production and metabolism in urine. And also with cortisol, you're seeing free cortisol in the diurnal pattern in saliva, but you're also seeing total production, which you see in the metabolites when you collect urine. So we say that you're getting more of a 3D story with urine versus the serum and saliva is more of a 2D story. And we're going to get to some examples of how that may be an important factor, particularly around estrogen metabolism, coming up. In addition, in urine and on the Dutch test, we get organic acid markers. These can tell us about nutritional sufficiency, oxidative stress, inflammation, nervous system, sympathetic nervous system stressors, melatonin, all of these easily tested in urine. So what might be the pros and cons of serum, saliva, and urine testing? In serum, the pros are LCMS serum can accurately measure estradiol and testosterone. It is the gold standard for measuring hormone levels. It's the gold standard because most research is on serum right now. And there are reference ranges available for children and teens. The cons are that it only captures hormone levels at a single moment in time. Patients have to travel to an office or lab for the blood draw, which that and the needle sticks can often cause a lot of anxiety, worry, and pain for patients. And serum offers limited to no information about hormone metabolism. In saliva, pros are it can be easily collected at home. It can be used to capture the cortisol diurnal pattern and the cortisol awakening response that we get first thing in the morning. Cons are that it may be less accurate for estradiol and testosterone. It only captures hormone levels at a moment in time. It offers no information about hormone metabolism. Those reference ranges greatly overlap, and common commercially available saliva immunoassays tend to be even less accurate than serum immunoassays. And most saliva labs are currently immunoassay. So what about saliva LCMS-MS? There are some labs that do offer this accurate, more sensitive testing in the saliva, but those measurements of saliva LCMS will be more accurate than saliva immunoassay. However, those reference ranges still overlap, and there's less hormone per unit of volume in the saliva compared to urine and serum. So it's really difficult to get clinically meaningful measurements with saliva testing, even when LCMS is used. In general, there's no known commercially available estradiol saliva assays with successful serum correlation data. So the important part here is that we can't correlate this with serum. And again, those reference ranges, which you can see here, really overlap. So we may not know if a patient is postmenopausal versus cycling luteal follicular levels. You can see those overlap there. So still not as good as serum LCMS or urine LCMS testing. In urine, the pros are that we get that ultra-sensitive LCMS testing. It can be collected easily at home. It captures average hormone levels over hours of time. It provides information about hormone metabolism. The cons are that it's not accurate in children under 9 years old or people with kidney disease or creatinine clearance issues. It does assume proper phase 2 metabolism of hormones, and that can be important, particularly around testosterone. In some cases, such as if a patient may have a UGT2B17 genetic variant, this alters their testosterone metabolism, and their metabolism is then not typical, and we get falsely low testosterone in the urine. So there is a pattern we see with this when we suspect testosterone is falsely low, and we would always double check that in the serum then. So what are the specifics around monitoring each route of administration for estradiol? So when we're monitoring estrogen therapy using serum, serum is most represented in the research. Reflects a single moment in time, and it can be useful when pharmacokinetic patterns are stable. So this is particularly around oral estradiol and estradiol patches, when the up and down pattern is very stable and you get an idea of what the hormone levels are from just one point in time, so from just one serum draw. So, for example, a single serum draw performed midway between patch applications can provide clinically meaningful data. If you look at the graph below, though, you can see if that blood is drawn too soon after a patch application, you may think that you're overdosing the patient. So for a patch that's switched out twice a week, you would measure estradiol in the serum 48 hours after applying that patch. But if you measured 12 hours, you're going to think it's really high. So timing can be very important when you're measuring those levels in serum. When the pharmacokinetic patterns are not stable, so things like transdermal estradiol, gels, and creams, vaginal estradiol, serum doesn't work as well. And we've graphed this out to the right. It's because those estradiols fluctuate a lot after supplementation. And so serum testing will yield very different measurements throughout the day within hours, depending on when blood is drawn. So 2 to 4 hours after application, you get very high levels, and just even 12 hours later, you get quite low levels, with even a couple rises and falls throughout there. So it's very unstable throughout the day. So it can be hard to pinpoint from a single blood draw. So, in summarizing that, serum is best for monitoring oral estradiol. Typically, we would draw that 6 to 12 hours after administration. It's best for monitoring transdermal estradiol patches, where the blood draw should be done midway between patch applications. It may not be best for monitoring vaginal estradiol or transdermal estradiol creams and gels. And again, remember, we're talking about the ultrasensitive LCMS method, not immunoassay, both for baseline and on therapy estrogen levels in postmenopausal women. What about monitoring estrogen therapy using saliva? Well, saliva testing is generally not recommended for monitoring estrogen therapy. Saliva data is limited, and there are no saliva testing outcome studies, and there are no known commercially available estradiol saliva assays with successful serum correlation data. When transdermal estradiol is used, salivary results don't correlate with clinical outcomes. For example, hot flashes, bone mineral density, vaginal atrophy. So you don't get those clinical outcomes like you're going to see in urine and serum. And that this statements are true for salivary LCMS assays, not just those salivary immunoassays. So saliva should not be used to monitor oral estradiol or transdermal estradiol, and that's talking about creams, gels, patches, etc. What about monitoring using Dutch dried urine? So Dutch dried urine may be ideal for monitoring transdermal estradiol, and that transdermal estradiol, we're talking gels, creams, mists, patches, anything applied topically to the skin. Those 4 dried urine samples provide exposure over 12 to 16 hours versus a single point of time, like serum and saliva. Urine results parallel serum, but they provide a better estimate of overall estrogen exposure. So when we say we're paralleling serum, the serum correlates with clinical outcomes, and so the urine is correlating with that as well. And in addition, we get to also measure that hormone metabolism. So it's a bonus. We're seeing both hormone levels as well as hormone metabolism patterns. So when we're talking about those metabolism patterns, we're going to get to measure phase 1 and phase 2 detox in the urine. So for example, when we're looking at estrogen, we can see if a patient is potentially favoring the carcinogenic 4-hydroxy estrogen pathways in phase 1, which may increase breast cancer risk. And we're looking at both levels as well as the ratio between the preferred pathway 2-hydroxy to that carcinogenic 4-hydroxy pathway. So important to look at that balance. We can also see if a patient favors the 16-hydroxy pathway, which is proliferative and may cause some women to have increased likelihood of breast tenderness or breakthrough bleeding. So again, we're looking at both the levels of that pathway as well as the ratio between 2-hydroxy, 16-hydroxy. We would also get to see how she's methylating her estrogen, which is phase 2. I don't have an example here, but it is something that you will see on the Dutch test. So monitoring using Dutch urine hormone testing is best for monitoring transdermal estradiol creams and gels, transdermal estradiol patches, and vaginal estradiol. It may not be best for monitoring oral estradiol, although you can still monitor estrogen metabolism patterns with oral estradiol. But with oral estradiol, you're going to get really high results. So you would use serum to monitor, and then you can also use Dutch testing to see how the hormone estrogen is being metabolized. We do have a summary at the end of this presentation, so you'll be able to print that out and have a nice handy guide. So lastly, what are the specifics around monitoring progesterone? So monitoring for prevention of endometrial hyperplasia using progesterone for that endometrial hyperplasia prevention. So data suggests it's not effective to use lab testing, not serum, not urine, not saliva, to guarantee the endometrial protection for patients on any progesterone therapy. So when studies are looking at to assess if progesterone dosing is protecting the endometrium, they're looking at endometrial biopsies, which typically are not indicated in a normal patient population to monitor that endometrial protection using a biopsy. So typically dosing and route of administration of progesterone are based on clinical studies that show protection, and those have found that oral micronized progesterone of 100 to 200 milligrams nightly or 200 milligrams 12 to 14 sequential days per month does protect the endometrium. So we just use a dose that's been shown to be protective of the uterus. But with Dutch urine testing, you can see how that oral progesterone is being metabolized. So you may not be monitoring levels, but you can look at the metabolism, which can be helpful because you may want to assess if the alpha or the beta pathway is more predominant. The alpha progesterone metabolites modulate GABA A receptors and generally support mood and sleep. So, for example, when someone's using oral micronized progesterone, and a patient might be favoring the beta pathway, as we see below, they may need a higher dose for the same benefit as a patient that's favoring the alpha pathway if you want to see similar improvements in mood and sleep for that patient. So let's jump into a case study. We're going to look at a 53-year-old female who is on hormone replacement therapy but she does have persistent hot flashes. So 53-year-old female, complaint of hot flashes, despite she's already started progesterone 100 milligrams and a transdermal estrogen patch at 0.025 milligrams. She started those 3 months ago. She is additionally applying 0.5 milligrams estradiol cream 3 times a week for vaginal dryness. We have some salivary immunoassay results, which were 4.6. We have those ranges down below. So that level of salivary estradiol 4.6, is it in the postmenopausal range? Yep. Is it in the follicular range? Yep. Is it in the luteal range? Yes. Is it in the ovulatory range? It is. So how is that saliva estradiol result helpful? Because she's in range across the board. What does that tell you? And how can you use that clinically? However, we do also have a 4-spot urine estradiol using LCMS collection. That is 0.51. And if we look at those ranges, we can obviously see quite quickly that her estradiol result falls within that low postmenopausal range. So no wonder she's still experiencing hot flashes. And that postmenopausal range you see there is 0.2 to 0.7. So that 0.51 right in the middle of that very low range. And remember, we want to get that above that range usually to see clinical benefit. So, if we look at her metabolism, we can also see she has a significant preference. Most obvious when we look at the bottom right in the slider bar ratio of the 2 hydroxy to 4 hydroxy. She's way over favoring that 4 hydroxy pathway. So, we see that preference. So, if we are going to continue, not just start her, but continue her on estrogen therapy at this point, we may want to lower that 4-OH preference. And there's lots of ways we can do that through diet or through supplements and through lifestyle. Some of those are listed there. And this over time may be helpful to lower her risk for potentially for breast cancer occurrence. Additionally, we get to see her cortisol diurnal pattern when we measured that Dutch test, and we found that her high cortisol was like she had high cortisol pretty much throughout the day. High cortisol also can be a contributor to hot flashes. All right, so let's get to some of those takeaways as we get wrapped up here. So we hope you'll consider Dutch testing, which is LCMS/MS over serum, as it captures average hormone levels over 12 to 16 hours of time, and it includes hormone metabolism patterns. Plus, it can be easily collected at home. Here's that overall summary, a nice table that you can print out that I mentioned earlier. It gives a great picture of when you might want to use LCMS, when you might want to use immunoassay, and then comparing serum, urine, saliva as well. So a handy reference for you all. So additionally, we do have a new free menopausal hormone replacement course available to our registered providers. We encourage you, if you're not already registered with Dutch, register, take this course. It will give you really good insight into primarily FDA-approved hormones like transdermal estradiol, vaginal estradiol, oral estradiol, etc., progesterone, vaginal DHEA. So highly recommend you check out this course. It has a lot of information in it. And I would just like to thank you all for being with us today. It's been wonderful sharing all of this information. I hope you found it very informative, and I hope you have a wonderful rest of your day.
For any questions or issues you may have, please contact Avexia Diagnostics by email at info@avexiadiagnostics.com or by phone 5 days a week at extended hours, 8 a.m. to 8 p.m. Eastern Time at 888-852-2723. Thank you, Dr. Ahnemann, for this informative presentation. Thank you again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Dutch Test, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.